If you walk into literally any busy emergency department on a Friday night or step behind the police tape of a complex crime scene, you are almost guaranteed to smell it.
Oh, absolutely. It's everywhere.
Right. It's on the breath of the driver in the trauma bay. It's in the blood samples sent down to the toxicology lab. It is, without a doubt, the most ubiquitous, socially accepted, and heavily marketed substance on the planet.
You see it at weddings, business dinners, on television.
Practically every restaurant. And yet, from a medico-legal perspective, alcohol creates the most confounding, multi-layered, and frankly dangerous forensic narratives you will ever encounter in your career.
It really does. It's a complete minefield.
So welcome to this deep dive. Today we are taking something incredibly familiar and stripping away the social context. We want to examine it with the absolute clinical and forensic precision it demands.
That is exactly the mission we're undertaking today. And to do this properly, we really need a rigorous, reliable framework. So our conversation today is built directly upon the structural spine of Simpson's forensic medicine. Specifically, we're going through Chapter 23, which details alcohol and its forensic implications.
But let's be entirely clear about our objective right off the bat.
Yes, crucial disclaimer here. If you are a medical student, a junior doctor, or a senior clinician, you cannot just listen to us chat for an hour and consider yourself prepped for the witness stand or the exam hall.
Definitely not.
This deep dive is a conceptual companion. We're here to help you understand the physiological why behind the textbook facts, the mechanisms driving the pathology, and, that strict, unforgiving discipline required for medico-legal documentation.
You really need to read Chapter 23 in Simpsons alongside this audio experience to truly lock in the foundation. This is not a replacement for the text.
Exactly. So we're going to trace the entire journey of ethanol. We'll start with the illusion of the drink itself, follow its absorption and metabolism through the human body, and break down the complex math used to track it.
The Widmark and Weineck stuff.
Yeah, right. We'll explore the clinical realities of intoxication and withdrawal, and finally, decode those highly testable post-mortem diagnostic puzzles it leaves behind.
It's basically the journey of a single molecule, from the glass to the autopsy table. I want to start right at the beginning with the concept of the drink itself.
The source.
Yeah. When you are taking a patient's history in the ER or reading a retrospective toxicology report, you constantly see alcohol quantified in units. But right away, Simpsons points out a geographical discrepancy that seems like a massive trap for anyone reading international research or documenting a legal case.
It is a massive trap. And honestly, it happens constantly in clinical practice. The concept of a standard unit is almost a complete illusion because it changes depending on where you are standing on the globe.
Which is wild to think about for a standardized science.
It really is. So in the United States, a standard drink or unit is defined as containing roughly 14 grams, or about 17.74 milliliters of pure ethanol.
Okay, 14 grams.
But if you cross the Atlantic to the UK, a standard unit is defined as just 8 grams, or 10 milliliters, of ethanol.
So the American unit is nearly double the UK unit.
Precisely. Now, imagine the clinical implications of that. Suppose you're a doctor in London reading a highly publicized American study on the cardiovascular effects of consuming 2 standard drinks a day.
Oh, wow. Yeah.
If you apply that American metric to your UK patient without doing the conversion, your baseline understanding of their toxicological load is entirely skewed. The literature highlights a very relatable scenario to show how quickly this becomes unmanageable.
The pub example, right?
Right. If you order a pint of strong lager at a pub, you are consuming about 3 UK units of alcohol. If you order the exact same volume of a low-strength lager, you're consuming just over 2 units.
Which means when a patient tells you, hey, doc, I only had 3 drinks, they are essentially giving you 0 actionable medical data.
It gives you absolutely nothing. 3 drinks is a completely subjective narrative. Was it 3 pints of an 8% IPA craft beer? Was it 3 standard, legally measured shots of 40% vodka?
Or 3 generous, free-poured glasses of 14% wine at a friend's dinner party?
Exactly. If a junior doctor simply writes in the clinical notes, patient reports having 3 drinks prior to the motor vehicle collision, that doctor has just laid a medico-legal trap for themselves.
Because it doesn't mean anything in court.
Right. When a forensic pathologist or a toxicologist is trying to reconstruct a timeline for a fatal road traffic accident or a complex assault case, subjective human reporting is useless. This is exactly why the legal system and the field of forensic toxicology had to develop objective mathematical frameworks.
Formulas we will discuss in depth later to cut through the noise of human memory and social definitions. But before we get to the complex math of how we measure it retrospectively, we have to look at the biological reality of the person consuming it. This is something that I think gets overlooked when we try to apply standard rules to a diverse population.
Oh, absolutely.
For example, what happens when we look at the aging population? If a 25-year-old and an 80-year-old both sit down and somehow consume the exact same chemically verified dose of ethanol, the resulting blood alcohol concentration isn't going to be the same, is it?
Not at all. And understanding why requires a shift from looking at the drink to looking at human physiology. As human beings age, our body composition undergoes fundamental changes.
Muscle loss and all that.
Exactly. One of the most significant changes is sarcopenia, the natural loss of lean muscle mass, coupled with a relative increase in adipose tissue or body fat. But the critical variable here is total body water.
Yeah.
As we age, our total body water percentage decreases significantly.
And alcohol is a water-soluble molecule.
Right. Ethanol is highly hydrophilic. It loves water. When you consume alcohol, it distributes itself throughout the water compartments of your body. It does not dissolve well into fat.
So fat basically rejects it.
Essentially, yes. So if an 80-year-old patient has significantly less total body water than a 25-year-old, the alcohol they consume is being distributed into a much smaller physiological bucket.
That's a great way to picture it.
Because the volume of distribution is smaller, the resulting concentration of alcohol in the blood, the BAC, will inherently be higher. Add to this the fact that hepatic function and overall metabolic clearance rates tend to slow down with advanced age, and you have a perfect storm.
They peak higher and stay drunk longer.
The elderly patient will reach a higher peak BAC and will stay intoxicated for a longer period. This is why forensic models and mathematical equations are just that, models. They are not magic.
The clinician or the pathologist must constantly adjust their interpretation based on the biological reality of the specific human being sitting in front of them. That concept of the biological bucket is a perfect way to visualize it. Let's trace the alcohol actually getting into that bucket. Let's talk about absorption. The drink goes down the esophagus and into the stomach. I think the common misconception is that the stomach acts like a sponge and absorbs everything immediately.
That is a very common myth.
But the literature is very clear that the vast majority of alcohol absorption actually occurs further down the line, right in the small intestine.
The stomach does absorb some alcohol, but it's relatively inefficient. The absorption occurs via simple diffusion across the mucosal lining. The reason the small intestine is the primary site of absorption comes down to basic anatomy and physics.
The surface area.
Yes. The small intestine is lined with millions of microscopic projections called microvilli. This creates a massive, almost unimaginably large surface area for diffusion to occur. The stomach, by comparison, has a relatively small and smooth surface area.
So it's basically a waiting room.
That's exactly it. Therefore, the rate at which you absorb a drink is entirely a slave to a single anatomical gatekeeper, the pyloric sphincter.
The valve between the stomach and the small intestine.
Right. Think of the pyloric sphincter as a toll booth on a highway. If that toll booth is closed, the cars, the alcohol molecules, are trapped in the slow lane of the stomach. And what keeps the toll booth closed?
Food.
Food. The text notes a fascinating physiological statistic. When ethanol is consumed with a heavy meal, gastric absorption accounts for up to 30% of the total alcohol absorbed. But when consumed with just water on an empty stomach, gastric absorption accounts for only 10%.
So eating a huge burger doesn't somehow magically soak up the alcohol, it just traps it in the stomach longer. Why does that matter so much for the final blood alcohol level?
Because of time and exposure, the longer the alcohol sits trapped in the stomach, the more time it has to undergo what we call first-pass metabolism.
The stomach breaks it down.
A little bit, yes. The gastric mucosa itself contains some metabolic enzymes, and some alcohol is slowly shuttled to the liver before it ever reaches the systemic arterial circulation.
So it's being dismantled before it even hits the main bloodstream.
Precisely. This slow, agonizingly delayed absorption dampens the peak blood alcohol concentration. You get a slow rolling hill on a graph. But if that pyloric toll booth is wide open, because you are drinking on a completely empty stomach, the stomach rapidly empties its contents.
It just dumps it all.
The alcohol flushes through the open toll booth, hits the massive surface area of the small intestine, and floods into the bloodstream all at once. Instead of a rolling hill, you get an explosive vertical spike in your BAC.
So food controls the toll booth. But what about the vehicle itself? What about the actual composition of the drink? The physics of the beverage has to play a role in how fast it crosses those membranes.
It plays a monumental role. We are dealing with concentration gradients. The optimal concentration for maximum rapid absorption across the gastric mucosa is a beverage containing between 20% and 25% alcohol by volume.
Which is an incredibly specific window. How does that actually translate to what people order at a bar?
Let's contrast two distinct drinking behaviors. Imagine a person drinking a standard pint of beer, which might be 4 or 5% alcohol. It has a very low alcohol concentration, but a massive fluid volume.
A lot of water.
Right. The sheer volume of the water in the beer dilutes the concentration gradient across the stomach lining, slowing the entire absorption process down. Now, imagine someone taking a straight shot of 40% overproof rum on an empty stomach. You would think that would absorb the fastest, but paradoxically, it doesn't.
Really? Why?
Because alcohol is a severe irritant. A high concentration of ethanol hitting an empty stomach irritates the gastric mucosa so violently that it causes the stomach to secrete heavy mucus, and it causes the pyloric sphincter to spasm shut in self-defense.
It literally locks the door.
It traps the high-proof alcohol in the stomach, slightly delaying the peak absorption.
So if beer is too dilute and straight liquor's too irritating, what hits that 20 to 25% sweet spot?
The mixed cocktail. A pre-mixed drink, like a vodka and tonic or a rum and cola. It has a relatively low total fluid volume, but the mixer dilutes the harsh spirit just enough to prevent the gastric spasm, placing the beverage right in that optimal absorption window.
That makes total sense.
This brings us to a highly testable clinical pattern recognized by forensic pathologists, the binge pattern. A binge pattern of drinking vodka and tonics on an empty stomach is significantly more likely to result in a rapid spike to a BAC above 80 milligrams per deciliter than if that same person consumed the exact same total amount of alcohol by sipping wine over a meal.
And there's a hidden variable in that vodka and tonic that makes it even more volatile, isn't there? The carbonation.
The carbon dioxide, yes. Carbonation actively alters the pharmacokinetics of the drink. The gas distends the stomach, which actually accelerates gastric emptying.
Like blowing up a balloon.
Exactly. It acts like a physiological override, forcing the pyloric sphincter open and dumping that optimally concentrated 20% alcohol mixture directly onto the microvilli of the small intestine. This is the physiological certainty behind the common phrase, champagne goes straight to your head.
It absolutely does.
Right.
Much faster than a flat, non-carbonated wine of the exact same alcohol content.
Exactly. Context is everything.
So for the junior doctor taking a history, or the forensic pathologist reconstructing a fatal fall down a flight of stairs, asking what were you drinking isn't just small talk.
It's vital forensic data.
The pharmacokinetics of 6 beers with a steak dinner are fundamentally mathematically different from 6 vodka sodas consumed in an hour on an empty stomach. The total grams of ethanol might be identical, but the clinical presentation, the behavioral impairment, and the peak BAC will be worlds apart.
Worlds apart. You have to understand the vehicle.
Let's follow the molecule. It has crashed the toll booth, flooded the small intestine, and absorbed into the bloodstream. Now we have to talk about how the body defends itself and clears the toxin. We're talking about elimination. The liver is the hero here. But how exactly does it dismantle ethanol?
The liver is the body's ultimate filtration plant, and it relies on a very specific 2-step enzymatic oxidation process. This is a core physiological mechanism that every medical professional must have committed to memory.
Okay, let's break it down. Step 1.
Step 1. The ethanol molecule is attacked by an enzyme called alcohol dehydrogenase, or ADH. This enzyme strips away hydrogen atoms, converting the ethanol into a new compound called acetaldehyde.
And acetaldehyde is the real villain of the story.
Oh, acetaldehyde is a highly toxic, highly reactive intermediate compound. It is actually much more toxic than the ethanol itself. In fact, it is responsible for the vast majority of the clinical miseries associated with drinking.
The hangover.
Yes. The profound nausea, the flushing of the skin, the tachycardia, the brutal headache of a hangover. These are not caused by the alcohol. They are the clinical signs of acetaldehyde accumulating in your tissues.
So the body has to get rid of the acetaldehyde immediately.
Right, which leads to step 2. Another enzyme, acetaldehyde dehydrogenase, rapidly swoops in and oxidizes that toxic acetaldehyde into acetic acid, which is basically vinegar.
From poison to vinegar.
Exactly. The acetic acid is then broken down into harmless carbon dioxide and water and eliminated from the body.
So ADH makes the poison, And acetaldehyde dehydrogenase clears the poison. But let's go back to the concept of the biological bucket, because I want to understand why two people can sit at the same table, drink the exact same amount of alcohol at the exact same pace, and have completely different blood alcohol concentrations.
We talked about age, yes.
But what about body mass and sex?
This is where forensic pathology relies heavily on the concept of the volume of distribution. As we established, alcohol is highly water-soluble. It distributes into the body's water, not its fat. Let's look at two hypothetical individuals who both weigh exactly 100 kilograms. One is a highly muscular, lean athlete. The other is clinically obese.
So the scale says the exact same number.
The scale is identical, but their tissue composition is vastly different. Muscle tissue is highly vascular and contains a massive percentage of water. Adipose tissue, or fat, is relatively avascular and contains very little water.
So the fat repels the water.
Right. Therefore, the obese individual has a significantly lower total volume of body water compared to the muscular individual of the exact same weight. If they both drink 3 shots of whiskey, the obese individual will have a notably higher BAC.
Why?
Because that same amount of alcohol is being dissolved into a much smaller physiological pool of water.
And this exact mechanism explains the inherent differences we see between male and female BAC levels in toxicology reports.
Precisely. It is strictly anatomical and physiological. On average, females inherently possess a higher proportion of adipose tissue and a lower proportion of body water compared to males of the exact same height and weight.
Which is a natural baseline difference.
Yes. Due to this natural fat-to-water ratio, if a female and a male of identical weight consume the identical dose of ethanol, the female will inherently exhibit a higher peak blood alcohol concentration. It is a simple volume of distribution.
But there's a flip side to that when it comes to clearing it out, right?
There is. However, the literature notes an interesting, slightly counterbalancing quirk regarding elimination. Studies have repeatedly shown that females actually eliminate alcohol from their bloodstream at a slightly faster rate than males.
Really? Why would females clear it faster if they peak higher?
It is believed to relate to liver mass. Females generally have a slightly higher relative liver volume to lean body mass ratio compared to men. More relative liver mass means more metabolic enzymes working to clear the blood.
That brings up a fascinating point about clearance rates. How fast does the human body actually process this out? If you're an ER doctor trying to figure out when a patient will be sober enough to safely discharge, what math are you doing in your head?
You are relying on the principles of zero-order kinetics. Most drugs are eliminated via first-order kinetics, meaning the body clears a certain percentage of the drug per hour.
So a half-life.
Right, a half-life. If the drug concentration is high, the body clears a lot. As it drops, the clearance slows down. Alcohol does not work that way. Alcohol elimination exhibits zero-order kinetics.
Meaning a flat rate.
This means the liver enzymes become saturated very quickly, and the body eliminates a constant fixed amount of ethanol per hour, regardless of how terrifyingly high the concentration is in the blood.
It's a conveyor belt moving at one speed no matter how much luggage you pile onto it.
That is the perfect analogy. And Simpson gives us very specific baseline numbers for that conveyor belt. For a standard moderate drinker who is fasting, the elimination rate falls within the range of 10 to 15 milligrams per 100 milliliters per hour.
And if they have food in them?
If the subject is non-fasting, the liver metabolism is slightly upregulated by the digestive process, and the rate increases to roughly 15 to 20 milligrams per 100 milliliters per hour. So a reasonable, safe average value for a forensic toxicologist to assume for a moderate drinker is about 15 milligrams per hour.
But there's an incredibly dangerous exception to that rule, isn't there? What happens when you are dealing with a severe chronic alcoholic? Their conveyor belt doesn't run at 15 milligrams an hour.
No, it doesn't. And this is a vital pathological mechanism that routinely complicates forensic toxicology. In chronic alcoholics, particularly during a detoxification phase, the elimination rate can jump to an astonishing 25 to 35 milligrams per 100 milliliters per hour.
They are clearing the alcohol more than twice as fast as a naive drinker. How is that biologically possible? Does their liver magically grow more ADH enzymes?
Not magically, but adaptively. It is due to the induction of a secondary metabolic pathway called the microsomal enzyme system, specifically cytochrome P450-2E1, or simply CYP2E1.
Okay, CYP2E1. In a normal moderate drinker, the standard ADH pathway we discussed earlier easily handles the load. But in a chronic, heavy, dependent drinker, the body is under constant, relentless bombardment by this toxic substance. To survive the onslaught, the liver adapts.
It builds a new road.
It basically realizes the main highway is permanently jammed, so it builds a bypass. It upregulates or induces the CYP2E1 system to help clear the massive ethanol burden.
It literally changes its own architecture to survive the poisoning.
Yes, this induction is a crucial physiological adaptation to chronic exposure. What this means in practice is that when a chronic alcoholic stops drinking, their liver is hyper-efficient, essentially running two massive enzyme systems simultaneously.
Wow. This accelerated clearance rate is something forensic toxicologists must account for. If you assume a standard clearance rate of 15 for a chronic alcoholic, your math will be entirely wrong.
Which is the perfect bridge into the math itself. We established how complex the human body is, the fat ratios, the stomach contents, the genetic enzyme inductions, but the legal system demands certainty.
Always.
A judge doesn't want to hear about microvilli and toll booths. A judge wants a number. How does forensic science turn all of this messy biology into an algebra equation?
It attempts to do so through the Widmark formula. E.M.P. Widmark was a Swedish physician working in the 1920s and 30s. He essentially wrote the foundational algebra for alcohol pharmacokinetics.
They still use it.
His equation remains the rigorous gold standard used in forensic toxicology and contested in courtrooms worldwide. It allows a toxicologist to estimate any one of 6 variables if they have the other 5.
Let's walk through those variables, because if you were going to testify in court, a defense attorney is going to ask you to explain this to a jury. Imagine Widmark's formula as trying to figure out how much water leaked out of a bucket. You need to know the size of the bucket, the speed of the leak, and what's left. What are the specific letters in the equation?
Let's break them down. In Widmark's equation, N represents the amount of alcohol consumed, usually in terms of the number of standard drinks.
Okay, N is number of drinks.
W is the body weight of the individual. Small r is the volume of distribution constant. This is the mathematical representation of that body-water difference we just spent time discussing.
Right. The fat versus muscle ratio.
It adjusts for the difference between a muscular man and an adipose-heavy female. Then CT is the blood alcohol concentration at a specific given time. Beta is the alcohol elimination rate, the speed of the conveyor belt, usually that 15 milligrams per hour we mentioned.
Got it.
Small t is the time elapsed since the first drink, and Z represents the fluid ounces of pure alcohol per drink.
There is also a constant of 0.8 in the formula. What is that doing there?
The 0.8 represents the specific gravity or density of ethanol. Ethanol is slightly lighter, slightly less dense than water. 1 fluid ounce of ethanol weighs approximately 0.8 dry ounces.
So it's a conversion factor.
You must include this constant to mathematically convert fluid volumes into physical weight, allowing the equation to balance.
Okay, let's put this into a real-world, high-stakes forensic scenario. The classic application of this is retrograde extrapolation. Paint a picture of how this is actually used in a criminal investigation.
Imagine a severe road traffic collision occurs at midnight. A driver strikes a pedestrian and flees the scene. The police track the driver down, apprehend them at their home, and a legal blood draw is finally taken at 3 a.m.
3 hours later.
Right. The lab analyzes the blood and finds a BAC of 0.08%. But the court does not care what the driver's BAC was at 3 a.m. while sitting in a police station. The court, the jury, and the law only care what the driver's BAC was at exactly midnight, the moment their vehicle struck the pedestrian.
So the toxicologist basically has to time travel using math.
Precisely. They use retrograde extrapolation. The toxicologist plugs the known variables into Widmark's formula, the BAC at 3 a.m., which is CT, the 3 hours that have elapsed, which is T, the driver's body weight, W, an estimated volume of distribution based on their sex and body type, R, and an assumed elimination rate, beta.
And they run it backwards.
By working the algebra backward, they might calculate that at midnight, the driver's BAC was actually 0.13%, well over the legal limit.
But listening to that, I can immediately see how a defense attorney would tear that apart on cross-examination. We just spent 20 minutes discussing how widely the R and beta values can vary.
And that is exactly what defense attorneys do. They will attack the assumptions. They will ask the toxicologist, how do you know my client's elimination rate was exactly 15 milligrams per hour? What if they have a slow metabolism?
What if they just ate?
Exactly. What if they had a massive steak dinner at 11:30 p.m., the toll booth was closed, and their BSC was actually rising between midnight and 3 a.m., meaning they were sober at the time of the crash but drunk when the blood was drawn?
Wow.
Widmark's formula is a brilliant model, but it is heavily debated because human physiology is not a closed mathematical loop.
Which brings us to a harsh clinical reality. If you are a busy ER doctor dealing with an unresponsive trauma patient at 2 a.m., you do not have time to sit down with a calculator and debate the nuanced R value of their body fat percentage.
No, you need an answer immediately.
You need to triage. Is there coma from the alcohol or from a subdural hematoma? Is there a faster way to do the math?
There is, and it is called Wynek's formula. Charles Wynek introduced a highly simplified back-of-the-napkin formula designed strictly for rapid clinical triage. It abandons the complex variables and relies on a single baseline assumption.
Which is?
On average, a 150-pound man will have a BAC of 0.025% after rapidly drinking 1 ounce of 100 proof or 50% alcohol.
So it's just a simple ratio?
It's purely ratio-based. You take the patient's weight, the estimated ounces consumed, and the proof of the alcohol, and you scale it up or down from that 150-pound baseline.
So give us an example.
So if a frantic friend runs into the ER and says, my 200-pound buddy just drank 5 12-ounce cans of 4% beer and passed out, you can quickly run Wynek's ratio in your head. It estimates his BAC at around 0.090%.
And what does that tell the ER doctor?
It tells them everything they need to know about triage. A BAC of 0.090% is intoxicated, yes, but it is absolutely not high enough to cause profound, unarousable coma.
So something else is wrong.
Therefore, the doctor immediately knows the unconsciousness is not just the alcohol. They need to rush the patient to the CT scanner to look for a fractured skull, a brain bleed, or push Narcan to look for an opiate overdose. It is a brilliant, life-saving triage tool.
But there is a massive legal warning attached to it.
The sternest warning possible. Wynek's formula is for clinical triage within the walls of the hospital only. If criminal charges, a trial, a deposition, or any court proceedings are going to ensue, Wynek's formula is entirely inadmissible.
It's just too basic.
It is too broad. Forensic and legal work mandates the strict employment of the Widmark formula with all its nuanced variables and documented assumptions.
So we've established how math tries to solve the mystery of what someone drank retrospectively. But out on the highway, at a police checkpoint, officers aren't doing algebraic equations. They're handing a driver a plastic tube and telling them to blow.
Right, breathalyzers.
We have to talk about evidential breath testing. How exactly does the air from your lungs legally translate into the concentration of alcohol in your veins?
It relies on a profound principle of physical chemistry called Henry's law of gas partitioning. To understand it, imagine an unopened bottle of sparkling water. The carbon dioxide is dissolved invisibly in the water, but there is a small pocket of air at the top of the bottle under the cap.
Okay, I'm picturing it.
The gas in the water is in constant dynamic equilibrium with gas in that air pocket. If you know the pressure and concentration of the gas in the air pocket, you can mathematically determine exactly how much gas is dissolved in the water.
And the lungs act like that bottle.
Precisely. Deep inside the lungs are millions of tiny air sacs, called alveoli, wrapped tightly in capillary blood vessels. As venous blood-carrying dissolved ethanol passes through these capillaries, the volatile ethanol easily diffuses across the ultra-thin alveolar membrane and enters the air spaces of the lungs.
So it just crosses right over into the breath.
When the person exhales, that deep lung air, the expired air, carries a concentration of ethanol vapor. According to Henry's law, the concentration of ethanol in that breath is directly proportionally linked to the concentration of ethanol in their circulating blood.
So the breathalyzer machine captures that air. How does it physically measure it?
The evidential devices used by modern police forces are highly sophisticated. They typically utilize an electrochemical sensor, commonly known as a fuel cell. When the subject's expired breath passes over the surface of this sensor, any ethanol present is chemically oxidized.
It burns it.
Essentially, yes. This specific oxidation reaction generates a tiny electrical current. The machine measures the strength of that electrical current, which is directly proportional to the number of ethanol molecules oxidized. The microprocessor then translates that current into a legally recognized digital BAC reading.
That sounds incredibly precise. But again, defense attorneys exist to find the flaws in the armor. What if the machine is reading alcohol that didn't come from the deep lungs? What if the driver has severe gastroesophageal reflux disease, GERD, and just silently burped up stomach acid containing highly concentrated, unabsorbed alcohol directly into their throat right before blowing?
Or what if they literally just swish with an alcohol-based mouthwash?
Exactly.
You are describing the classic mouth alcohol defense, and it is the bane of forensic evidence. If a machine oxidizes pure, highly concentrated alcohol sitting in the mucous membranes of the mouth, it will generate a massive electrical current and produce a falsely astronomical BAC reading, completely misrepresenting the actual blood levels.
So how does the medico-legal system protect against that? Because people do use mouthwash.
Through unbreakable operational discipline. Forensic science is well aware of these physiological pitfalls. To overcome them, jurisdictions apply strict mandatory observation protocols. Typically, an arresting officer must sit with the subject and observe them continuously for a mandatory waiting period, usually 15 to 20 minutes, before they are allowed to administer the breath test.
Why 15 minutes specifically?
Because residual mouth alcohol, whether from mouthwash or a regurgitative burp, is highly volatile and will naturally dissipate and evaporate from the oral cavity within 10 to 15 minutes. By waiting 20 minutes, ensuring the subject does not burp, vomit, or put anything in their mouth, the officer ensures that the breath sample provided is genuinely from the deep alveolar lungs.
And what if the machine just glitches?
Furthermore, the evidential machines are programmed to require two separate, distinct breath samples taken a few minutes apart. If the two readings differ by more than a very narrow, mathematically permitted margin, the machine assumes contamination and automatically aborts the test.
So the protocol is the protection.
And if a subject genuinely has a medical condition, like severe chronic reflux, that prevents a reliable breath sample, protocol mandates that breath testing be abandoned entirely and replaced by direct blood or urine analysis.
Now, speaking of drawing blood, there is a very specific nightmare scenario detailed in the literature that applies directly to junior doctors working in the emergency department. If you are a doctor and the police ask you to draw a legal blood sample from a suspected drunk driver, or if you're simply treating a patient near an evidential breath testing machine, what is the one everyday clinical product you must treat like radioactive material?
Oh, this is critical. Alcohol-based hand sanitizers and alcohol-containing skin swabs. The isopropyl alcohol or ethanol in these standard hospital products will absolutely destroy a forensic case.
Paint that picture for us. How does a little tiny prep swab ruin an entire legal case?
Imagine a junior doctor is asked to take a legal blood draw from a DUI suspect. Habit takes over. The doctor rips open a standard alcohol prep pad, vigorously swabs the patient's antecubital fossa, inserts the needle, and draws the blood.
Just standard procedure.
As the needle passes through the skin, it drags trace amounts of that highly concentrated topical alcohol directly into the vacuum tube. When the forensic lab runs that sample, the BAC will be artificially, dramatically elevated.
Because it's measuring the swab, not just the patient.
The chain of evidence is fundamentally corrupted. When that doctor is called to the witness stand, a defense attorney will utterly destroy their credibility and the case will be thrown out.
And it affects the breath machines too, right?
Absolutely. The electrochemical sensors in breathalyzers are exquisite alcohol detectors. If a nurse or doctor stands next to the machine and vigorously rubs their hands together with alcohol-based hand sanitizer, the evaporating alcohol vapors in the ambient room air can be drawn directly into the machine's intake.
Causing false positives.
Exactly, causing interference or false positive baseline readings. The rule is absolute. When dealing with forensic toxicology sampling, you must exclusively use non-alcoholic alternatives, such as aqueous chlorhexidine or betadine swabs.
That is a practical pearl that will undoubtedly save someone listening to this from a brutal cross-examination. Let's shift gears from how we measure the molecule to what the molecule actually does to the brain and body. Let's explore the clinical effects of alcohol. We all know ethanol is a central nervous system depressant.
Yes.
The clinical trajectory is a well-documented continuum. As blood concentrations rise, the initial feelings of relaxation and social disinhibition give way to blurred vision, loss of fine motor coordination, slurred speech, and impaired judgment, leading to severe risk-taking behavior.
We've all seen it.
As the levels continue to push higher, the profound depression of the central nervous system leads to unconsciousness, coma, and eventually it suppresses the autonomic functions of the brainstem, leading to cardiorespiratory arrest and death. But here is the central thesis of the entire forensic textbook chapter, the fallacy of the single BAC.
This is perhaps the most important conceptual framework we will discuss today. A single, isolated BAC value just a number printed on a toxicology report, has very little clinical or forensic meaning on its own, other than confirming that the ingestion of alcohol occurred.
Wait, really?
You cannot look at a number on a page and definitively declare to a jury, this is exactly how this patient was behaving.
Why not? I mean, if the math is right, shouldn't the behavior match the concentration?
Because of tolerance. Tolerance profoundly alters neurochemistry. The text drives this home with a stark, highly memorable differentiation. A blood alcohol concentration exceeding 0.40%, that is 400 milligrams per deciliter, is an absolutely massive, overwhelming toxic dose.
4 times the lethal limit in some places.
If a naive drinker, say a teenager who has never consumed alcohol before, somehow rapidly ingests enough to reach a 0.40 BAC, it will almost certainly be lethal. The alcohol will rapidly suppress their medullary respiratory center. They will simply stop breathing and die.
But what if that exact same 0.40 BAC is found in a chronic end-stage alcoholic?
The presentation will be entirely different. In a chronic alcohol-dependent individual, their brain receptors have literally downregulated and adapted over years to function while bathed in a central nervous system depressant.
So they're used to it.
That exact same BAC of 0.40% might produce few, if any, outward clinical symptoms in the dependent drinker. They might be awake, walking, conversing reasonably well, and exhibiting fine motor control that would baffle an observer.
They might not even look drunk.
They might even be driving a car with terrifying competence. This is why the forensic pathologist and the clinician must interpret the toxicology in tandem with the clinical picture and the patient's history. The raw number does not dictate the narrative.
When we look at morbidity and mortality, when alcohol actually kills, we have to recognize the patterns. If an intoxicated person doesn't die from direct pharmacological suppression of the brainstem stopping their breathing, what is the other major, highly common lethal mechanism associated with severe acute intoxication?
Aspiration. It is a mechanical, asphyxial death driven by the pharmacology of the drug. Alcohol does several things simultaneously.
To the gut, right.
Yes. It relaxes the lower esophageal sphincter, making reflux highly likely. It acts as a severe chemical irritant to the gastric lining, frequently inducing strong vomiting reflexes. And crucially, as a CNS depressant, it profoundly depresses the level of consciousness and ablates the protective gag reflex in the airway.
So you can't cough to protect your lungs.
Yeah.
That is a deadly combination.
It is the perfect storm for asphyxiation. If a severely intoxicated, unconscious individual is lying supine on their back and they vomit, their body cannot recognize the danger. They cannot cough or clear their airway. They passively aspirate the highly acidic, thick gastric contents directly down the trachea and into the lungs.
That's horrible.
This violently blocks the airways and causes massive chemical pneumonitis, rapidly leading to asphyxiation and death. It is one of the most common tragic findings in forensic autopsies of acute.
And what about the long-term chronic pathology? Forensic pathologists are experts at pattern recognition. When you perform an autopsy on someone who has consumed heavy amounts of alcohol for decades, the disease leaves a very clear cascading signature throughout the body, doesn't it?
It absolutely does. The internal architecture of the body is totally transformed. The primary target, of course, is the liver. The pathology progresses in stages. It begins as fatty liver disease, or steatosis, where the liver becomes enlarged and yellow as fat droplets accumulate.
And then it scars.
Over time, this progresses to alcoholic hepatitis, which involves active inflammation and necrosis of liver tissue. Finally, it results in dense, nodular, fibrotic liver cirrhosis. The liver shrinks, hardens, and essentially turns to solid scar tissue.
But the liver simply failing isn't usually what kills them suddenly in an ER setting, is it? It's the cascade effect of that scar tissue.
Correct. The cirrhotic liver becomes incredibly dense. The main blood vessel supplying the liver, the portal vein, tries to push blood through this dense scar tissue but encounters intense mechanical resistance. This creates a state of portal hypertension, massive back pressure in the venous system.
Like trying to push water through a kinked garden hose.
Exactly. And that high-pressure blood has to find a detour. It forces its way into smaller, delicate collateral veins, particularly those lining the lower esophagus.
Well, they're embarrassed.
These thin-walled veins engorge, stretch, and balloon out, creating what we call esophageal varices. Think of them as severe, fragile varicose veins bulging into the throat. Because they are so fragile and under such high pressure, they can rupture spontaneously or from the simple act of coughing or vomiting.
And when they rupture,
It results in catastrophic torrential gastrointestinal hemorrhage. The patient rapidly bleeds to death internally, vomiting massive amounts of bright red blood. It is a terrifying, rapidly fatal event that is a direct mechanical consequence of years of alcohol abuse.
and the heart takes a hit too, right?
Yeah. Furthermore, pathologists frequently observe associated heart failure, specifically alcoholic cardiomyopathy, where the toxic effects of ethanol cause the heart muscle itself to become flabby, weakened, and dilated, unable to pump effectively.
We've talked about how the presence of alcohol kills acutely and how it kills chronically over decades. But there is a hidden killer here, a vital clinical blind spot that the literature explicitly warns junior doctors about.
Yeah.
It is not just the alcohol that kills, it is the sudden, unexpected absence of it. Untreated alcohol withdrawal is a medical emergency.
It is a profound medical emergency with a high mortality rate if missed. This scenario plays out in hospitals every single day. A chronic, dependent patient is admitted to the surgical ward. Perhaps they fell while intoxicated and suffered a fractured neck of femur, or maybe they're in for a routine gallbladder removal.
Right.
Because they are in the hospital, they are suddenly completely cut off from their daily alcohol supply.
And their brain chemistry just panics.
Panics is the perfect word. Their central nervous system has been bathing in a powerful depressant for years. To compensate, their brain has vastly upregulated its excitatory neurotransmitters just to achieve a baseline level of function.
To stay awake.
When you suddenly remove the depressant blanket of alcohol, that massive excitatory overdrive is left entirely unopposed. It is like taking your foot off the brake of a car while the accelerator is pinned to the floor.
What does that look like clinically?
Initially, it presents as severe anxiety, diaphoresis or heavy sweating, tachycardia, and a pronounced fine tremor of the hands. If clinical staff do not recognize these early warning signs and intervene, the patient will rapidly cascade into severe alcohol withdrawal syndrome,
ETTs.
culminating in delirium tremens, or DTs. This involves profound confusion, terrifying visual and auditory hallucinations, massive autonomic instability where their blood pressure and heart rate skyrocket, and potentially fatal grand mal seizures and cardiovascular collapse.
How does the medical team prevent this? You can't just give them a beer.
By using standardized objective clinical tools. The standard of care is the Clinical Institute Withdrawal of Alcohol Assessment Scale, commonly known as the CIWAR protocol. This scale requires nurses and doctors to rigorously assess and assign numerical scores to specific symptoms. The tremors, the sweating, the anxiety, the agitation.
To tracking it mathematically.
By tracking this score, clinicians can quantify the exact severity of the withdrawal and manage it aggressively. They essentially replace the alcohol with a safer, medically controlled depressant, typically high-dose benzodiazepines like diazepam or chlordiazepoxide, carefully tapering the dose down over several days to safely land the patient's neurochemistry back to normal.
That is a phenomenal breakdown of the clinical realities. Now, I want to take a sharp turn into the final and frankly most baffling section of our deep dive. We shift from the bustling emergency department to the cold steel of the pathology suite. After a person dies, the forensic narrative of alcohol gets incredibly complicated.
Oh, it becomes a nightmare.
Why? Because a decomposing corpse can literally act like a clandestine brewery. Alcohol can be spontaneously synthesized inside the body after death.
Post-mortem neoformation of ethanol. It sounds like science fiction, but it is a relentless diagnostic puzzle that forensic pathologists and toxicologists must solve in almost every case involving a decomposed body. The biological mechanism is entirely driven by putrefactive bacteria.
Where do the bacteria come from? Are they just environmental?
We all carry them.
Huh.
As the human body begins to decompose after death, the immune system fails, and the diverse bacterial species naturally present in our gastrointestinal tract are free to migrate. They breach the gut wall and spread rapidly through the bloodstream and soft tissues.
And they can make alcohol.
Crucially, many of these bacterial species possess their own metabolic enzymes, specifically their own versions of alcohol dehydrogenase and acetaldehyde dehydrogenase.
So they literally have the factory equipment. What are they using for raw materials?
They act upon the carbohydrates naturally present in the human body tissues, primarily stored glycogen or cellular lactate. The bacteria consume these carbohydrates, convert them into pyruvate, and then enzymatically ferment the pyruvate directly into ethanol.
So the bacteria are essentially brewing beer inside the blood vessels.
Exactly. The implications for forensic toxicology are massive. Imagine pulling a body from a river after a week. You draw a sample of femoral blood, send it to the lab, and it returns a highly elevated BAC of 0.15%.
You'd assume they were drunk when they drowned.
A layperson or an inexperienced investigator might immediately assume the decedent was heavily intoxicated when they fell into the water. But in reality, they might have been entirely sober at the time of death. The bacteria synthesized every single drop of that alcohol post-mortem.
That is terrifying from a justice perspective.
Yeah.
How does a forensic pathologist differentiate between a victim who was actually drunk and a corpse that was just brewing alcohol? The literature gives us the keys to solving this, and it comes down to tissue specificity and scene correlation. The bacteria need food carbohydrates to make the alcohol. And as we know, carbohydrates are not distributed equally throughout the human body.
That is the physiological anchor you must memorize. You have to look at where the glycogen is stored. The liver is the body's primary energy storehouse. It is absolutely packed with glycogen, roughly 8 grams per 100 grams of wet tissue weight.
So the liver is a feast.
Therefore, the liver provides an absolute feast, an unlimited buffet for these putrefactive bacteria. If neoformation is occurring, the post-mortem alcohol production in the liver will be vastly higher than in other tissues.
Now contrast the liver with the eye.
Yes, the vitreous humor, the clear gelatinous fluid that fills the globe of the eyeball. The vitreous humor is a sequestered, highly protected environment. More importantly, it has virtually no glycogen, only about 90 milligrams per 100 grams of fluid.
Almost none.
It is essentially just water, salts, and collagen. Even if bacteria manage to migrate into the eyeball, which is difficult, there's absolutely no substrate there for them to convert into alcohol.
So the eye is a pristine time capsule.
Precisely. Therefore, if the alcohol is produced entirely post-mortem by bacterial fermentation, toxicology will show a wildly high alcohol concentration in the liver blood, but the vitreous humor will test at near zero. The discrepancy solves the puzzle.
What environmental factors at the scene should immediately put the death investigator or pathologist on high alert that this bacterial party might be happening?
Heat and physical trauma are the primary accelerants. Temperature is critical. If the patient suffered terminal hyperthermia before death, for example, a raging fever from severe systemic sepsis or an overdose of a stimulant drug, their core body temperature is already elevated.
So they're warm when they die.
The body becomes an optimal pre-warmed incubation chamber for bacteria the moment the heart stops. Similarly, storage of the body at high ambient temperatures, such as a decedent found in a closed apartment during a summer heatwave or a body in the trunk of a car, will massively and rapidly accelerate bacterial proliferation.
And what about trauma? How does that speed it up?
Any severe physical trauma that disrupts the integrity of the bowel will act as a catalyst. If a body experiences severe crushing injuries or massive deceleration forces like those seen in high-speed aircraft accidents or severe train collisions, the gastrointestinal tract is often violently torn open,
Spilling the bacteria.
This spills massive amounts of highly active gut flora directly into the nutrient-rich, carbohydrate-heavy body cavities, immediately jump-starting the fermentation process. In aviation pathology, post-mortem ethanol production is expected as the rule rather than the exception.
Okay, let's pull all this together into the definitive diagnostic framework. This is high-yield, foundational knowledge. You are the pathologist. You have a body. You have a positive blood alcohol reading. How do you definitively prove, beyond a shadow of a doubt, whether it was ante-mortem ingestion or post-mortem production? Walk us through the rules. Rule number 1, look at the alternative fluids, look at the urine, and look at the vitreous.
This is the gold standard approach. We already established that the vitreous humor has almost no carbohydrates, making it highly resistant to post-mortem bacterial production. The exact same physiological principle applies to urine.
Right. Urine is sterile, usually.
Unless the decedent was suffering from severe uncontrolled diabetes and was actively spilling high amounts of glucose into their urine, normal human urine contains absolutely no carbohydrates. The bladder is a sterile vault with no food for bacteria. Therefore, if a person was actively drinking alcohol before they died, that alcohol will have circulated in their blood, filtered through their kidneys into the urine, and diffused deep into the vitreous of the eye.
So if you test the femoral blood and find a high BAC, But the urine and the vitreous fluid both come back completely negative for alcohol.
Then you can state with incredibly high confidence that the individual was sober at the time of death and the blood alcohol was an artifact produced post-mortem by bacterial putrefaction. However, if the blood, the urine, and the vitreous all test positive for ethanol, you have definitively proven ante-mortem ingestion. The person was drinking.
And if they were drinking, we move to rule number 2, the ratios. This is where it gets brilliantly analytical. By comparing the urine alcohol concentration, the UAC, to the blood alcohol concentration, the BAC, the pathologist, can act as a forensic timekeeper and determine exactly where the decedent was in their timeline of intoxication when the fatal event occurred.
This is a beautiful, elegant application of pharmacokinetics to a forensic puzzle. You have to think about how these fluids accumulate. The blood alcohol is a dynamic, real-time snapshot of the exact moment the heart stopped beating.
But the urine takes time.
But the bladder stores urine over a long period. Therefore, the urine alcohol concentration represents a lagging, accumulated average of what the kidneys have been filtering over the past several hours. By comparing the snapshot to the average, you reveal the timeline.
Let's break down the specific ratios. What if the UAC is lower than the BAC?
If the urine alcohol concentration to blood alcohol concentration ratio is less than 1:2, meaning the blood level is significantly higher than the urine level, this definitively confirms that ethanol concentrations in the blood were actively rising at the exact time of death.
The toll booth was open.
Exactly. The individual was in the pre-absorptive or active absorption phase. They had recently consumed a large amount of alcohol, and it was still violently flooding from their gastrointestinal tract into their bloodstream much faster than the kidneys could filter it down into the bladder. They died while their intoxication was still getting worse.
What if the ratio flips? What if the UAC to BAC ratio is greater than 1:3?
If the urine concentration is significantly higher than the blood concentration, the decedent was in the post-absorptive stage. They had stopped drinking, their stomach was empty, the liver had been steadily clearing the alcohol from the blood, causing the BAC to drop.
So they were sobering up.
But the bladder was acting as a reservoir, holding on to the highly concentrated urine that was produced hours earlier during the absolute peak of their intoxication. They died while sobering up.
And finally, what if the ratio is massive? What if the UAC is much, much greater than 1:3?
A massively elevated urine ratio strongly indicates heavy, sustained, continuous consumption over a prolonged period of time. The kidneys have been filtering massive amounts of ethanol for hours or days, completely saturating the bladder contents, while the blood levels might have fluctuated or begun to drop just prior to death. It paints a picture of a prolonged binge rather than a single acute ingestion.
It is genuinely amazing how much of a detailed, minute-by-minute narrative a skilled pathologist can reconstruct from just a few isolated fluid compartments. We've traced this molecule from the geographic definitions of a pint glass through the microvilli of the gut into the metabolic bypasses of the liver, exhaled across the alveolar membrane, and finally measured in the pristine fluids of the human eye. It is a staggering journey.
It is, and it underscores the complexity of our field.
As we wrap up this deep dive, I want you, the listener, to carry a specific lingering thought into your next clinical shift or your next review of a forensic file. We have spent the last hour dissecting how the legal system and the medical field desperately tried to put a neat mathematical number on intoxication. We use Widmark's formula from the 1930s. We use standardized unit measurements. But here is the reality. Our population is rapidly aging. Obesity rates and baseline body compositions are fundamentally changing across the globe. Polypharmacy patients taking 5, 10, 15 different interacting medications is becoming the baseline standard, altering liver enzymes in ways we are only beginning to understand.
The baseline is shifting.
So the question you have to ask yourself is this: are rigid mathematical formulas designed a century ago still going to hold up in the adversarial courtrooms of tomorrow? Or is the standard drink and the standard elimination rate an illusion we're eventually going to have to abandon entirely in favor of individualized genetic and enzymatic profiling? The numbers are a guide, but they are not the gospel. You must always advocate for the complex clinical truth over a simple statistic.
That is the perfect summary of the forensic mindset. Question the context always.
Okay, before we completely sign off, we're going to do a quick shift handover. I'm going to run through 7 rapid-fire, single best answer style prompts, just like a senior clinician giving you a quick curbside consult to test your reflexes on what we've discussed today. I will ask the question, I'll give you a second to lock in your answer, and then we will reveal the solution and tell you exactly where in Simpson's Chapter 23 you need to go if you need a refresher. Here we go. Prompt 1. Which specific anatomical site is responsible for the vast majority of alcohol absorption, and how does the presence of a heavy meal alter the pharmacokinetics of gastric absorption?
Pick a second.
Got it. The answer is the small intestine, due to its massive surface area of microvilli. A heavy meal keeps the pyloric sphincter closed, trapping the alcohol in the stomach. This increases gastric absorption up to roughly 30% compared to only 10% with water. This slows down the overall peak rate of absorption and allows for more initial first-pass metabolism by the gastric mucosa and the liver. If you missed the mechanics of this, revisit the absorption section in the text. Prompt 2. You are reviewing the toxicology of a severe chronic alcohol-dependent individual in detox. Why might they demonstrate an ethanol elimination rate of 25 to 35 milligrams per 100 milliliters per hour compared to your moderate drinker who clears it at roughly 15 milligrams per hour?
Lock that in.
Okay, what's the reason?
The answer is the physiological induction of the microsomal enzyme system, specifically CYP2E1. The liver adapts to chronic, relentless toxic exposure by upregulating the secondary metabolic pathway to run parallel to the standard ADH pathway, dramatically accelerating clearance. Revisit the elimination of alcohol section.
Prompt 3. When applying Woodmark's formula retrospectively, the elderly population often presents a severe complication. Do elderly patients tend to show an elevation or a depression of their actual BAC compared to younger individuals drinking the exact same dose? And what is the primary physiological reason why?
Think about the bucket.
Have your answer.
They tend to show a marked elevation of actual BAC. This is driven by a high variation in the Woodmark R factor, primarily a significant decrease in total body water as muscle mass is naturally lost and fat composition changes with age. The alcohol is forced to distribute into a much smaller fluid volume, concentrating the dose. Revisit the ethanol sources and concentrations section.
Prompt 4. You are interpreting a highly contested post-mortem toxicology report. The decedent was found in a sealed apartment during a summer heat wave. The liver BAC is extremely high, at 0.18%. However, the vitreous alcohol concentration is absolute zero. What is the definitive forensic explanation?
We just covered this one.
Lock it in.
The explanation is post-mortem neoformation of ethanol by bacterial putrefaction. The liver contains abundant glycogen, roughly 8 grams per 100 grams of tissue, which serves as a massive fuel source for bacterial conversion into alcohol. The vitreous humor contains negligible amounts of carbohydrate, effectively preventing bacterial fermentation in the eye. Revisit the post-mortem considerations section.
Prompt 5. A decedent on the autopsy table has a urine alcohol concentration to blood alcohol concentration, a UAC to BAC ratio of less than 1 to 2. What does this specific ratio indicate about their ingestion status and timeline at the exact moment of their death?
Remember the toll booth.
Got it.
A ratio of less than 1 to 2 confirms that ethanol concentrations in the blood were actively rising at the time of death. The individual was still in the pre-absorptive or active absorption phase of ingestion. Alcohol was entering the blood faster than it was accumulating in the bladder. Revisit the post-mortem consideration section.
Prompt 6. A naive 18-year-old non-drinker and a 55-year-old chronic end-stage alcoholic, both present to the emergency department trauma bay with a confirmed BAC of 0.40% or 400 milligrams per deciliter. What is the fundamental difference in their anticipated clinical presentations?
Think about the single BAC fallacy.
Lock it in.
The naive non-drinker is in critical condition, at severe risk of lethal cardiorespiratory arrest and profound central nervous system depression due to brainstem suppression. The chronic alcoholic, however, may present awake, conversing, and with few outward symptoms of severe intoxication due to massive neurochemical tolerance. Revisit the clinical effects of alcohol section.
Prompt 7. Listen closely if you are working in the ER. What specific, everyday clinical product must be strictly avoided by medical staff when taking legal blood samples or working near an evidential police breath testing device to prevent the destruction of a forensic case?
This is a career saver.
Got your answer.
You must avoid all alcohol-based or alcohol-containing hand washes, sanitizers, and topical skin prep swabs. Their use can directly contaminate blood samples via the venipuncture needle or cause severe interference with the electrochemical fuel cells in the breathalyzer, leading to false elevations. Always use chlorhexidine or betadine. Revisit the ethanol measurement section.
And that wraps up our deep dive into the complex world of ethanol. Thank you for joining us for this extensive forensic journey. As always, we urge you, do not let this audio be the end of your studying. Open up the book, read the corresponding chapter in Simpson's Forensic Medicine to solidify these concepts, and remember to always question the physiological context behind the raw numbers on the page. We will see you on the next one.